For those of you who don't know who I am, I'm actually a physician. I've been in leadership roles for the last 20 years, Department of Medicine Chief and Medical Director, short time as the Medical Director of Emerge, Physician Lead for Flow and Utilization, and then I was drafted to be the physician lead to bring on the doctors when we transformed into an EMR in 2017, followed by 5 years where I led the analytics department that blended the decision support, business intelligence, case costing, coding together. Secretly though, I wanted this job because I wanted the opportunity to get data into the EMR so that we could use it. And I'm here to tell you about our story. So by the end of this presentation, this is the overview. We'll cover the following: learning how mapping clinical needs to data solutions begins with workflow analysis, learning the importance of designing analytics tools for clinicians and having them use it. You will see how high clinical user engagement will blend the clinical and analytics world, and finally how improving patient outcomes will really light on fire analytics at the bedside and improve data fluency. So Mackenzie, just for those of you who don't know who we are, we're a hospital, two-site hospital just north of Toronto, serving Vaughan and Richmond Hill, about 785 beds, 48,000 admissions, and 230,000 emergency visits. So this was our digital journey. In July of 2017, we installed Epic as our EMR, but that's not important, the vendor. 15 months later, we became HIMSS 7. And then 2 years after that, we earned our first HIMSS Davies Award for Clinical Excellence. In 2020, we won the 3M Award for Excellence in Stroke Care. 2022 revalidated for HIMSS 7 again, followed by our second Davies Award last year in June. And this year, Class Organization gave us an Excellence Award for physician and nursing engagement. So for those of you who don't work with physicians, that's something you can't get. It's like herding cats, I heard. So this was the satisfaction survey. We participated in it. The Arch Collaborative of Class had 183 hospitals across the world. 118 of them were Epic organizations, and we scored a net score of 78.1, which is the positive score minus the negative experience questions. Sorry, scratchy throat. So we had the third highest score in the world, behind Johns Hopkins, Aramco in Saudi Arabia, and a hospital in Brazil. Just to put it in perspective, the other Epic hospitals, the average is 53, and the other Epic hospitals in Ontario is at 40. So we think this is one of the reasons why we achieved our successes. So I'm going to show you 7 moves to HIMSS 7 and on to data heaven. Number 1, assemble the right team. You will recognize these 4 guys. They delivered us a gold medal in the men's 4x100 relay this summer. How did they do it? Absolute trust and teamwork. In a perfectly run relay, each member starts to run up on each leg as the team member is approaching, and the precision handoff is just as important as their runs. Number 2, connections. Healthcare organizations are really good at putting people into silos. Executive team, the clinical folks, clinical operations, clinical informatics, data analytics. What's important is that we connect everybody together, beginning with looking at their workflow in the live production environment and designing for that workflow so that it's intuitive and easy to use. And that's where analytics needs to connect very heavily with the clinical informatics department in order to feed into every stage of that. Everybody cooperates to get their product out into live production, and it's the connections that remain important. So this was our framework for all our success stories. I'm not going to lie, we have the same challenges as everybody else. Missing data, workflows that don't get used, data quality issues. It's entropy inside an EMR, and you need good systems to make sure that everything keeps working. So each stakeholder group has a role in each leg of the project. So clinical operations, or the project lead or executive sponsor, needs to define the problem you're trying to solve, followed by a good deep dive into the workflow analysis. And so that's usually done by the clinical teams, the clinical ops, and clinical informatics. They'll go through several cycles of designing, redesigning, training, and deployment. And then analytics has the role at the bottom at every stage. During the problem statement, they can provide baseline data. And then in workflow, they can take a look at the compliance critical control points where analytics will help. And during the design phase, you just have to keep shouting, put in structured data, get rid of all that free text. And during the evaluation phase, that's where analytics carries the baton to the finish line. So I just want a word about human factors engineering of user experience and user interface. This is the road for an enjoyable, seamless EHR experience. So we were a small cottage hospital. We don't have a whole team that looks at, how things look and feel. We don't have a commercialization department, et cetera. Everybody just needs to know this. So put things in the right place where we can find it, pay attention to alert fatigue. And this might mean intuitive layouts, workflows that are streamlined, structured data versus free text. Don't get people to duplicate entry just so you can collect data. Smart alerts that fire to the right people at the right role at the right time. Pages of numbers won't get acted on. You guys recognize those pages of numbers? Heat maps, trend lines, stacked bar charts, frequency histograms, benchmarking will get their attention. Hi, Sunny. Recognize that? This is a graph of how many cases were in target versus out of target, and this shows very clearly how the surgical team is doing in terms of getting cases under target. I'm going to show you some examples during our COVID story. So the data cycle, again, begins with workflow understanding at the 12 o'clock position. You guys are familiar with the data mining, data quality, data cleaning cycle. So an integrated EMR gives you access to all of those things which are structured data in the EMR. They are elements of a data tree that are accessible on tables, and users are clicking drop-down menus and predefined fields. So this is the stuff that lends itself to real-time dashboards if you have high user adoption. And then the EMR becomes more than just a documentation tool. It's something that you can use to track things in real time. And then the year after you go live, that's when analytics comes alive, so that you can, they can take that data to the next step. The data then should be presented in a way that allows for multiple iterative cycles of insight, action, and measurement in a short amount of time, in a short interval of time. Okay, so pushing cleaner data collection upstream so you can populate real-time dashboards is dependent on high user engagement. So I've written the engagement scale up the x-axis. The first is you just inform, you email people, and then you can persuade them to do a sell job. You can involve them and start dialogue, or you can really get their opinion when you consult them. But the pinnacle of engagement is to allow champions to actually co-create. At our hospital, we actually have physicians and nurses sitting together with our clinical informatics teams on a weekly basis, solving problems together. On the x-axis is the participation level. So what you have are champions, which are a small group in the upper right-hand corner. They're engaged and they all come to the meetings and they're highly present. The middle group, they're positive, but they follow the champions. And then you have the late majority who will show up, but they might not be fully informed. I put stethoscopes on the left because often clinical folks are the ones that add a lot of value, but they're very scarce and they may not come to the meetings. And then you have the hostages and resistors in the bottom corner who neither show up nor bother to be informed. What you want is the champion group to eat up the majority and make them like themselves, and then decrease the resistors and the majority. So that's kind of what happened at our hospital. So why should you care? Because clinical user engagement makes life easier for the analytics team. The year after you go live, like I said, that's when analytics will come alive and you take them on the journey for the analytics. So 2 years after we went live, we went on a purposeful hospital-wide safety journey, which was from the top down. So this is medication reconciliation, workflow analysis. We try to make order out of this mess that comes in with the patient. And usually the pharmacist helps the doctor do their job, but most of the time it's the doctor doing it by themselves. And so you don't get medication reconciliation on time, as you would think. So you put in things into the EMR and then you measure what the pharmacists and the doctors are doing. So by 2021, this was a game changer. We put TV screens on the wards with actually the analytics that could show everybody. This held the doctor, the nurses, and everybody accountable because everybody could see it, including the patient's families. And when I walked by, I knew my metric was still red. I would try to turn it green because I'm a little competitive. So this is where all the sources of data came from. And this was our results. For medication reconciliation, we had to do a bunch of things to make that happen. But in the end, what happened was those electronic boards and allowing the pharmacist to do part of our job because doctors always need help. So our length of stay for patients who had it early versus late was very consistent across all of these quarters over 3 years. People who had their med reconciliation done early had almost a whole day length of stay lower than if they were done late. Okay, on to the COVID story. So you're familiar with this picture with the pandemic. The whole idea is manage the surge, reduce the spread, try not to kill anybody. So our analytics team put the patients into a COVID registry. Everything to do with the COVID patients were put into this registry so that we could base all of our analytics on it, send it to public health, et cetera. So this was one of our dashboards. When we saw a positivity rate of 5%, we knew we were getting an inpatient surge. If those people were older, we knew we were getting an inpatient surge. If it was in the pediatric population, we were getting an emerge surge. And then we did geolocation as well. It informed our emerge director where to put the testing sites and the mobile teams. So then we were thinking, oh no, we are always plugged up in our hospital. Is there a way that we could do some of this at home? So this is the workflow for our remote COVID monitoring program. Different parts where safety measures were put in. We managed patients at home using this. This is what the patient would see. They were entering their data at home, and if they entered an abnormal result, a message would pop up telling them to go to the emergency room. And this is what the doctor would see. This is what I was talking about, structured documentation versus free text. This is me clicking in a patient while I was talking to them on the phone. It takes less than a minute and a half to be able to do this, using speed buttons or drop downs versus free text boxes. And then it does one of three things. It does three things at once. One, it makes it easier for me to capture data with the patient. Two, it actually made a note from the template. And three, it structured the data so we could do analytics on it. So this is a dashboard on how the patients were uptaking the technology. So because this dashboard was available to us every week, we were able to push their adoption from 15% up to 55%, because you wouldn't know unless you measure. This one is from the symptom measurement. We found out from the respirology group, i.e. my group, that if you were really short of breath and you were coughing like crazy all day long, you probably had pneumonia. And so out of our 6,000 patients, 950 of them went for chest x-rays, of which 2/3 of them actually had pneumonia. And we wouldn't know unless we were tracking this. So a whole suite of dashboards showed us a lot of things. We even did resource matching from this. As the volumes went up, I found out that doctors could take care of about 15 patients a week. And so when the volume surged, I had to add doctors to the clinic. So what about the inpatient management for COVID? We were bombarded with a lot of recommendations from England, from Italy, from the United States. We had to make sense of it all. And when we decided that UK had it right, because they published in New England, they did their randomized trials quickly for us, we were to adopt the dexamethasone for the low oxygen patients. But the trick was that UK taught us to start oxygen early rather than the normal time of 89%. It started oxygen at 94%. So how do we get that into the EMR? We changed our order sets. We changed the thresholds for the nurses. We reminded people, we had alerts. And then we tracked when the doctors were starting oxygen. So you can see there in the spring of 2021, most doctors were starting oxygen, most patients were started on oxygen at higher levels than normal. And that's something because physicians are really normally slow to adopt new recommendations, and anything new, they usually resist. So they were on board with all of this. So these graphs represent compliance to treatment standards. In the top left, you'll see that July 7th, 2020 was when that New England Journal article was published, and right at that moment was when we started to adopt the dexamethasone in orange. On the far right is remdesivir, the antiviral treatment. On the bottom is tocilizumab. You don't see as high of a usage because that was restricted. Now on the right, we also graphed what kind of oxygen was being used. And unlike most hospitals, we actually use high-flow nasal cannula, which we found to be equivalent to intubating patients. Now, this is a medical thing. Intubating COVID patients often led to their death because there's a lot of complications with being paralyzed and not being able to breathe for yourself. So the nasal cannula allowed people to get through their COVID without being intubated. And so when we found that out, which was in green, we started to open dedicated high-flow wards because we also, with all of our analytics, found out it wasn't leading to spread like what every other hospital was thinking. So then we had to adapt. As the Omicron wave came, there was this ministry directive that said not everybody who has COVID will have COVID or die of COVID. They just have it and they're in for something else. So then they sent out guidance documents to us. And we programmed that into our EMR, to our registry, that anybody who was COVID positive as an inpatient, who was on oxygen, who was on the COVID treatment, we'd say those people really had COVID. Otherwise, they were COVID positive and they were in for something else. So we kept that designation all the way through into even when the patient's outcome, discharged, or death, so that when we submitted the diagnosis of public health significance, at the end, the deaths were also classified into the individual buckets. So we had an accurate representation of the different kinds of COVID deaths from admission all the way to the death. And we asked the doctors to participate because we put that in front of them when they were filling out the death certificate. So we were tracking mortality in real time. And like I said, using the different kind of treatment, we found out we could save those 80-year-olds that everybody was making a DNR. And I'm proud to say I discharged a 103-year-old during that time period. We knew that males were sicker than females from our data, and that over 80, they would go to the ICU. Now, those we heard on CNN and we heard on the news as well, but actually we knew that internally before we were told that from the news. So we found out in real time that this was happening. So when vaccines became available in 2021, I said to the guys, you know what, it would be great if we could track the vaccine uptake on the patients coming in. As you know, those of you in Ontario, the vaccines were put into another database other than your own database. So separate databases, interoperability, et cetera, et cetera. I guess we'll talk about that later. I was thinking, how are we and we were a vaccine center, but we were entering it into the provincial registry and not our own EMR. So how are we gonna know who has the vaccine, who doesn't? So I sat around going, hey guys, can we get the doctors to do it? No, don't get doctors to do anything, they won't comply. Can we get the nurses to do it? Oh, they're too busy. Should we ask NPs to do it? We don't have enough of them. So in the end, medication reconciliation was a process that almost went on universally with all the patients. We said, pharmacy group, you guys did so well in medication reconciliation. Do you think you guys could put in the vaccine for us? And you know what they said? We're vaccinating people, we'll put it in for you. So every single patient had their vaccine status in the header of their EMR, and that informed the doctors who was under-vaccinated, who was fully vaccinated, what was gonna happen to them. And this is the data. Sunny, I think this was you again. Anyway, what I have here is 0 doses, 1 dose, 2 doses, and the under-vaccinated people are in orange. And what you have there on the stacked bar charts is the age group. So you can see in 2021, by the August of 2021, most of the 80-year-olds were vaccinated. They were not coming into the hospital. However, the 60 to 80-year-olds and 40 to 60-year-olds were waiting for their turn in the vaccine. They started to pile into our ICUs. On the right there, I have the deaths, and the deaths were occurring in that 40 to 60, 60 to 80 age group because they were under-vaccinated. So we didn't know we were doing that well until after, when we looked at our data. We were participating in a Gemini study, which was 24 hospitals in Ontario. And they phoned us and said, hey, can you tell us why you guys did so well? So most other hospitals had 8% of their population as COVID patients. And I don't know if you know, but we opened a new hospital in 2021. The Premier called our CEO and said, can you guys be our COVID relief hospital instead of opening as a full-service hospital? And so for about 4 months out of 2021, we only took care of COVID patients on all the wards and all our ICU beds. And so 15% of our patients were COVID patients. And when you're inundated with a pandemic like this, your mortality and your length of stay could suffer, but we actually had the 4th lowest length of stay despite having the most number of COVID patients. Mortality data, we had the most number of COVID patients, 1,861, of which 275 of them went through our ICU. And we had one of the lowest mortality rates of all top 10 medicine diagnosis. So here is the length of stay. We graphed Mackenzie in purple at the bottom, and the rest of the province in orange are peer hospitals, which are hospitals in other hotspots in similar populations in green. And you could see our length of stay was consistently lower than everybody else. This was our crude mortality comparison. Our mortality rate was persistently lower than everybody else for our peer group, as well as comparing to the rest of the province. So adjusted for age, sex, transfer, Charleston comorbidity index, length of stay, admission type, we were still lower than our peers and the rest of the province. The methodology was from CIHI, and internal factors were adjusted using logistic regression. So in the end, We took care of the most number of COVID patients, but the mortality rate was lower by 14.5% compared to the rest of the province. The risk-adjusted length of stay of COVID patients after the first wave was 37% lower than the rest of the province, and we were in the 25th percentile in terms of length of stay management. So how did we do this? Analytics supported the capacity management, the treatment guidelines, the adherence to these guidelines, and we kept the eye on the ball for the hospital for the length of stay and mortality throughout. As a respirologist, I felt pretty helpless in the spring of 2020. I had gone through SARS in the early part of my career in 2004. I didn't think I would have to do that again. But this time it was different. It was at home. It was in the schools. The malls were closed. The restaurants were closed. The whole world was affected. So having contributed to the analytics of COVID gave me and all the staff hope through the healthcare crisis of our time. Thank you.
Great. So we do have time for questions. Please raise your hand if you've got a question, and we'll get a mic out to you. Over there in the back.
Yes.
Get a mic over to that fellow.
Or I can project.
All right, well, you can yell it out and we need us to repeat.
You can try to yell that. Well, Victoria, thank you. I watched this great story of success, and in hindsight, the proposition of a real-time analytics, real-time data, thank you, it comes as a no-brainer, right? Like, well, of course. You spoke of that bubble of resistors and detractors, and I wondered if you can give some examples of the most common phrase that those detractors have put forth in that work, and how do you actually grow that bubble of champions? Any pointers there? Thank you.
So I'd like to think of me as the lead champion. Hopefully I was. Actually, I can be a resistor, I can be a late majority, I can be the major majority as well. So you have to get into the mind of the person who's saying that. So during this time, I didn't say, the leader of our physician union was very much against this whole EMR, saying, why are we going through all this work, all this money that's being spent? Is it worth it? Are we saving money? Are we saving lives? And so internally we said, we have to show the doctors that this will help the patients. Doctors don't care too much about saving money, but they do care about better clinical care. So once we started proving story after story the EMR was helping, those guys actually some of them turned into champions from being a resistor. The other thing is, you might hear, oh, why do I have to put in all these flow sheet rows? It used to take me 5 minutes to chart the exceptions, and now I have to go through 2.5 hours of charting. Why am I doing that? Well, then you need your professional practice leads to tell them, look at what we did with CLABSI. We actually decreased the falls by using this technology. People are not breaking their hips and then dying of it within the first year. So even the nurses will come on board with that. The clinical folks are the typical resistors. Everybody else works for the hospital. They get a paycheck from the hospital. They'll listen, they'll do their thing. But it's the people that are sort of unionized and also outside the hospital's purview that are the most difficult. The doctors were, they're sort of like looked at as the most resistor. That's why I put a stethoscope up there. But they can be your greatest champions. If you get a doctor on board in with your teams. See, I was embedded in clinical informatics, analytics, and also I had this whole history with operations for the last 20 years. So I understood what everybody was talking about. Whenever I was talking to finance, it was like, look, good clinical care always saves money. Right? Because people fall and they stay in the hospital a long time. If I was talking to the doctors, same thing. Not about money, but good clinical care is really good for our reputation. It's good for us. It makes you feel good, but that's why you became a doctor. So, and I think it's infectious. We were talking with Bobby on the phone yesterday. I think it behooves us to make math exciting for everyone again. I know everybody's like, oh, I was never good at math. These graphs are really easy for everybody to understand. This is what's happening over time. This is in buckets of age groups. You have to make it easy for people to look at a graph and get it right away. If they're looking at a giant table of numbers and you have to correlate this column with that column, you're going to lose your audience.
Great. Another question over here. And for the panelists coming up now, if you haven't gotten mic'd up, then head to the booth in the back.
I'm just curious to know, sorry, where you think AI tools like AI Scribe and those sorts of things will help in terms of your resistance of your physicians in making documentation and all of those things easier. Do you anticipate that this will help, or do you feel like you might take a few steps back before you see that climb?
So I'll quote the vice president at the time, Victoria, you better do this with no scribes. We're not paying for scribes. So scribes are someone who follows a doctor around and then types in everything that is happening with the patient. Now there's AI tools for where there's ambient listening, and they can actually go into your EMR and then start typing everything that's happening, the conversation that's happening between the patient and the doctor. So we don't have any of that. We started it in 2017 in the era without artificial intelligence or scribes. I've heard that the hospitals in the States that have implemented, the doctors are at least 22% happier. But we're in Canada, we're not in the United States. Making doctors happy is pretty low on the totem pole when it comes to budgets, right?
Excellent. All right, thank you very much, Victoria. You get a big round of applause.